Good evening, aspirants. Today's class is on rheumatology. It will be taken by Dr. Varun Pushkarna. Sir, you can start taking the class.
Good evening, aspirants. Last time we covered until.
Good evening, sir.
Good evening. Last time we covered until scleroderma. So we'll take up another topics now. We'll begin with gout. Now, gout is very important. Gout and pseudo gout. These are basically classified under which kind of arthropathy? Anyone?
Crystal arthropathy.
Yep. So it is basically a crystal arthropathy, and in some patients and in some scenarios, it is usually asked as monoarthritis. So usually it is classified under monoarthritis and crystalloarthropathy. So gout is a crystalloarthropathy due to deposition of monosodium urate microcrystals within or near the joints. So it's not necessary that it should be inside the joint, it can be near the joints as well. It is usually caused by chronic hyperuricemia, that means uric acid levels more than 450 micromoles per liter. And essentially it is due to some secondary effect of a drug that decreases the renal excretion of uric acid, or it is because of CKD. In chronic kidney disease also, the excretion of uric acid is decreased. Uric acid is formed from purine metabolism. So it is a byproduct of DNA denaturation. It usually causes monoarthritis. Most common joint to be involved is the big toe of MTP in more than 50% joints, 50% cases. It is indeed the most common inflammatory arthritis in men and women above 60 years of age. Now, as I told you, uric acid is byproduct of purines. So the hyperuricemia can occur as an imbalance between uric acid production. Now, purine degeneration occurs whenever you are treating a solid cancer also. Solid cancers, bone marrow tumors, hematological cancers. So whenever you are treating them, the damage of the cells at a large scale leads to destruction of DNA at a large scale. So this leads to obviously more uric acid formation. That is why when the patients of these kind of malignancies, when they are started on chemotherapy, the uric acid load suddenly increases, leading to gout, and sometimes uric acid encephalopathy also occurs. So the uric acid production is increased in malignancies, and specifically when the malignancies are treated by chemotherapy. And the second reason is when the excretion is decreased. So whatever is being produced will accumulate gradually and gradually because the excretion is decreased, leading to symptoms of gout. So what are the increased production of uric acid syndromes? So one is the cancer, second is cytotoxic drugs, then severe psoriasis, any autoimmune disease which is very, very aggressive, they can lead to this, and Lesch-Nyhan syndrome, beer, even non-alcoholic beers, they can lead to hyperuricemia. Can anyone tell me what is Lesch-Nyhan syndrome?
HGPRT deficiency, hypoxanthemic hypospasticity.
So, okay. So
Sir,
you tell.
HGPRT is deficient.
Okay. So there is HGPRT depletion. What kind of depletion? Depletion means it was present earlier on.
What's the question, sir? Sorry.
What is Lesch-Nyhan syndrome? Very important. There are many patients in UK who have Lesch-Nyhan syndrome.
Hyperuricemia. Hyper.
So, as you are saying, it is HGPRT is what? Deficiency or depletion?
Depletion.
No, it is a deficiency. See, it is a X-linked recessive disease. So the gene is deficient, thereby the enzyme is not formed, leading to accumulation of uric acid. Are you getting it?
Yes, sir.
Yeah. So
Yes.
now you have to understand that this is a complete deficiency. This is a complete deficiency. Can somebody tell me what is the disease with partial deficiency of HGPRTase is known as? Can anyone do that? It is very important. Many times I asked this question. This question had come to me when I was giving MRCP exam. Any
Sir,
idea?
sir, Kelly-Sigmiller syndrome.
Wonderful. So it is known as Kelly-Sigmiller syndrome. It is the younger brother of Lesch-Nyhan syndrome. Now, there is a partial deficiency. Do I have a space? Yes. So, there is a partial deficiency of HGPRTase, that is hypoxanthine guanine phosphoribosyl transferase enzyme. Now, this is involved in the metabolism of purines. This also clinically manifests as hyperuricemia, uricosuriasia, which is lost in urine, gout, and urolithiasis. So typically you will have a patient who is like 28 years old male. They will be all male by
X-linked, sir. Yes.
it is X-linked recessive
X-linked,
disorder.
yes.
That is why. So it will eventually lead to many symptoms of Lesch-Nyhan, but not mental retardation. It is not seen in Kelly-Sigmiller. Self-mutilation is not seen in Kelly-Sigmiller. They are people who are walking amongst you and I, going to normal schools, normal intelligence, but they are suffering from defective metabolism of purines. Is that okay? Which are the drugs which lead to this? So diuretics, famous drugs leading to hyperuricemia, aspirin, cyclosporin, pyrazinamide, renal failure, alcohol, lead toxicity, and of course, Down syndrome. Clinical presentation. I told you it is classically a monoarthritis, usually recurrent. First MTP joint is the most common. This is acute gout. Then is chronic gout, that is gouty nephropathy. And it leads to deposition of the crystals in the Bowman's capsule, the tubules, and the interstitium. So everywhere uric acid is deposited, leading to stone formation eventually, that is nephrolithiasis. Then chronic tophaceous gout. So tophi are formed, articular, periarticular. Usually in the exam it is said that there are white patches on the skin which when pressed express white chalky material from them. This is usually the line which is mentioned in the exam. So don't get puzzled. What is it? It basically is the chalky material is the uric acid crystals mixed with the calcium they coming out. Now, because I told you it is basically a condition of monoarthritis. For example, a patient comes to you with a complaint of monoarthritis. What is the best step that you do?
Aspiration.
Yes. So you do a joint aspiration. Now, let us see the permutations. If the joint aspiration shows negatively birefringent, crystal shaped, needle shaped crystals, what is it?
No.
If it shows positively birefringent,
Soda gout.
rhomboid shaped crystals, it is
Chondrocalcin. No,
it
rhombus.
should CPPD or
Soda gout.
pseudogout. Wonderful. So arthrocentesis is a definitive diagnosis for all monoarthritis. This will show negatively birefringent needle-shaped crystals under polarized light. Radiography will show large punched out cystic erosions in gout. Can you tell me which are the erosive gastritis? In the last lecture we read about it. Erosive arthritis. Number 1 is rheumatoid arthritis. What about SLE?
No, it is not erosive.
Wonderful. So, in the exam, you will need to differentiate rheumatoid arthritis from SLE. I will give you a case scenario. Sorry if I keep going back because rheumatology is a comparative topic. Unless you know how to compare between two things, you may be lost. So, usually the question comes like this, that there is a 50-year-old female coming with polyarthralgia, skin rash, leukopenia, all the small joints of hand and feet are swollen and tender. X-ray of hands shows erosions, periarticular region. ANA is positive. Rheumatoid arthritis factor R factor is positive. NT-CPA is positive. What is the diagnosis? First answer will be SLE. Second will be rheumatoid arthritis. Third will be Sjogren. What is the answer?
Rheumatoid arthritis.
Rheumatoid.
Why?
Anti-CCP antibody is positive.
Yes, and also there is erosive periarticular region.
What about ANA?
ANA may be positive in rheumatoid also.
What fraction of patients?
30% to patient.
Up to 15% of patients of rheumatoid arthritis can have positive ANA.
Sir, why there is a skin rash?
Rheumatoid arthritis can also have rash.
Yes, if there is splenomegaly.
Okay, sir.
So rheumatoid arthritis can have rash because of small vessel or small vessel vasculitis usually. Okay?
Okay, sir.
Okay. So, coming back to osteoarthritis, this is also an erosive arthritis, but the erosions are cystic in nature. Okay? And more so, it is a monoarthritis. Not all the joints will be involved. So, there are cystic erosions on the X-ray. Uric acids, usually during acute attack, are normal in 30% of the patients. That means even at a normal uric acid level, you can diagnose gout. Acute gouty arthritis, you can still make a diagnosis. Treatment, you should let it resolve unless it doesn't add diclofenac, drug of choice. NSAIDs. This is drug of choice. And sometimes you might need, along with that, intralesional steroids. There is a question which had come in MRCP, and I'm still so fond of that question. I keep telling everyone, I'll just write it down here. I haven't written it in the questions. I'll tell you. So there is this guy who had come with a monoarthritis of knee joint. Joint aspiration showed negatively birefringent needle crystals, and the patient has acute gout. The patient was started on diclofenac plus colchicine and diclofenac, colchicine and some aspiration was also done? Very interesting question. Now, this patient comes back after 7 days with same problem. No improvement. What are you going to do? Run your horses. Say anything.
You
So
want to
aspiration and culture.
Great,
Say-
yes, and culture.
septic.
Say again.
Aspiration and culture.
Yes. No culture. No culture.
Aspirate, only aspirate.
Purely aspirate.
Aspiration.
Just aspirate. There are crystals inside the joint. The crystal load is very much. That is why the patient is not improving. Because where does colchicine act? Anybody? What is the
The
mechanism of
neutrophil.
action? Say again.
It's
It's micro
reduce.
polymerization.
Somebody is wonderful. Microtubule formation of spindles is inhibited. That means it can only stop further making of uric acid because of spindle formation is not there. So can you imagine that initially the purines that were made for spindle formation, they will be destroyed and there will be increase in the uric acid formation?
Yes, so more uric acid will be there.
Yes. So initially these patients can have actually worsening of the gout. So what will happen? The crystals will be even more. So there was no intralesional steroid in that answer. The other answer was start the patient on allopurinol. That was also not the answer. Start the patient on febuxostat. That was also not the answer. Sorry, the calls are coming. I don't know why so many calls are coming. Okay. So the answer was simple knee aspiration. Aspirate as much crystals you can aspirate from the joint so that the joint, because it is the crystals which are causing the inflammation. No, you take out the crystals, there will be no more inflammation. Is that clear?
Okay, sir.
Yes. All right. So this brings to me a very, very important question. There was another question that a 60-year-old man with gouty arthritis and coronary artery disease with LVEF of around 50% on diuretics has persistent symptoms. Number one, the patient is on allopurinol 100 milligram 3 times a day with no major relief. So patient has chronic gout with no major relief. What is the next best step? Number one, increase the dose of allopurinol. Number two, shift to febuxostat. Number three, give rasburicase. Number four, decrease diuretics. Number five, intralesional steroids. The EF is around 30%. Yeah. So tell
Sir,
So
me what.
increase allopurinol. Number one.
dose of allopurinol.
Sir, you wanted the best choice or wanted two choices that you can reduce the
You can
diuretic
500.
or give rasp.
So what is the most correct answer?
Probably
Rasburicase.
I go for decreased
Okay.
diuretic.
I will give you the best answer. No problems. What is the this nice guidelines for management of chronic gout? Start at allopurinol 100 milligram per day. This is the drug of choice. I'll tell you a very interesting thing in the meanwhile during the course. Allopurinol 100 milligram per day is the starting dose. You go up to 100 milligram 3 times a day. The patient is already on 100 milligram 3 times a day. The next guideline is do not stop allopurinol until the maximum dose is achieved. What is the maximum dose? Anyone?
Sir, 900 milligram per day.
900 milligrams per day. So the dose is 300 milligrams 3 times a day.
Okay.
Another interesting thing, iske niche the next guideline is febuxostat is another allopurinol, like it is this xanthine oxidase inhibitor. Another xanthine oxidase inhibitor which has a marketing approval for allopurinol resistant gout. Now, this changes the way you think. Febuxostat has just a marketing clearance, and that too in which patients? In allopurinol resistant cases. That means unless you have given the patient 900 milligrams of allopurinol per day, you cannot start the patient on febuxostat, unlike what we do in India. Here we start the patient directly on febuxostat. But that is now how MRCP will take the question. Is that clear?
Yes, sir.
Yes, sir.
Okay, sir.
So that is a practice changing definition for you.
Sir,
Yes.
sir, can I ask one question, please,
Yes, please go ahead.
related to this? Sir, I am doing DM critical care in a final year exam going. We are seeing the oncological emergency like tumor lysis syndrome, and sometimes some isolated uric acids are high. At that time, can we use
Yeah.
the febuxostat or something else we have to use, like isolated uric acid is high?
Very nice question. So
I think raspberry case is the drug of choice.
yeah, what is the cause of tumor lysis syndrome? Only then we can reach the answer.
Yes, sir.
What is the cause of tumor lysis syndrome?
Like uncontrolled growth of cells, na, sir. Like that's why the purine metabolism is more and uric acid levels are high.
Uncontrolled what?
Like growth of cells, like it's a more common
No,
in
no, no, no,
hematological
no, 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 no,
It's
no,
more
no.
destruction of cells.
It is destruction. It is the
Yes,
tumor lysis, not tumor growth syndrome. It is
Yes, sir,
tumor
yes, sir.
lysis syndrome. It happens when you give chemotherapy,
Chemotherapy.
which is tumorcidal. So when so much of purines are released, immediately our body upgrades the xanthine oxidase job, and there are a lot of uric acid crystals. Uric acid is formed, but then it crystallizes because it is excess. Now, it is the load which is there. The enzyme is working day and night. And in fact, resburicase has to be started before giving chemotherapy. It gives more better results. But even
Yes,
if you have not given it before chemotherapy, give it as soon as possible. And remember, it is an acid which gets crystallized in an alkaline environment. So avoid the pH, avoid the blood to become alkaline. The more alkaline the blood will be, more crystals will be formed. Are you getting my point? So keep the
Yes,
patient hydrated, keep the urine flowing, and yes, and stay away from over enthusiastic correction of the metabolic acidosis.
yes, sir.
Do correct hypocalcemia because it will be there. And resburicase is the drug of choice.
Okay.
All of the other drugs will need their time. They are what do you say? Competitive inhibitors. So competitive inhibitors have no reputation in the world of chaos. They will be overturned by the excess amount of uric acid.
And how much dose to be given, sir, for resburic?
That is a class for matter for some other day.
Okay, okay, sir. Thank you.
Yeah. Okay. So immediately you give cocodamol and resburicase, which is discussed.